And there is a bit of stigma attached to the title. Unfortunately, I do hope that the science and awareness and things and conversations like this helps change that. So IBS, it's an acronym that stands for Irritable Bowel Syndrome. It's incredibly common. About 1 in 5 adults, the prevalence changes as the criteria sometimes changes for the diagnostic framework that we use. But in simple terms, this is a condition where the gut and the brain aren't quite communicating right. It shows up as those gut symptoms we mentioned before, so pain, bloating, and those unpredictable bowel habits. And indeed, we see a lot of women that are being diagnosed with IBS for the first time during perimenopause, and the research backs up that is indeed really occurring, and it's a real pattern. Or that women are first reporting symptoms or in symptoms that are worsening for the first time in their life before and during that menopausal period. So when we think about IBS, it comes under a banner of disorder of gut-brain interaction, formerly known as functional bowel disorders. And that word, disorder gut-brain interaction, I've already talked a little bit about that disordered signaling between the gut and the brain, so the brain hyper-reacting to what's happening at the gut level.
All right. Well, it's a real pleasure to have Dr. Jess Biesiekierski on the show today. Welcome.
Hi. Thank you, Zora, so much for having me.
I'm glad I got your name right. It's a mouthful when you read it, but your name deserves to be highlighted because your work, and I'd love for you to share later on your research as well, what you are finding in the research and tie this in. But menopause is such a massive shift in our biology. And I see so many women in my community with gut issues. I would say 80% of them. And they've got bloating or pain. They've got unpredictable bowels. They maybe IBS. There's so much going on. So why are we seeing so much change in the gut in this stage of life?
Yeah. And thank you for sharing that. I see that in the participants and patients that I interact with as well. So for anyone listening, if you absolutely have noticed that your gut is acting differently as you're going through menopause, so that more bloating, distension, predictable bowel habits, which could vary from bloating, constipation, diarrhea, gas, flatulence, wind, all the fun stuff, maybe even gut pain. And that gut pain may come on after a meal, or you may not even be able to notice that relationship of when the symptom onset occurs. You are not imagining it. You are definitely not alone. And why it's happening, and particularly why it's happening biologically at this life stage, is because estrogen and progesterone, these are those hormonal receptors, they actually sit all through your gut. And this means that they're not just in the reproductive system, which is perhaps what we might think of or have thought of traditionally when we think menopause, but actually all throughout your gastrointestinal tract. So when those hormones are dropping and changing throughout that menopausal cycle and period, your gut's nervous system and the way that food is moving through also really changes. And those changes, which are real and they're measurable biology, then leads to different sensations that your gut and your brain are not so used to interpreting and experiencing. Importantly, these symptoms are not all in one's head. It is not because one is getting older. It is because indeed there is differences that are occurring in how the gut is behaving and responding to food through those hormonal receptors.
The way I understand it then, because there's so many receptors in the gut, and when we don't, estrogen receptors, let's say, and progesterone, when we don't have those anymore, and no matter how healthy you are, they're going to go. It's nothing we can really do other than replace them. But I'm trying to understand mechanistically what's happening. The gut isn't getting the signals from estrogen to do what it needs to do. So it's kind of like, whoa, I don't know what to do here. And that's maybe why some of these symptoms are happening. I mean, you could explain it at a more scientific level than me, but
I think it all comes down to that signaling cascade. So when we think about how our gut is interpreting any sensation, and a clear sensation is when you are digesting food, eating food, something that for when one is normally digesting food, that food passing through, perhaps there is water being absorbed, nutrients being absorbed, different fermentation effects, gas being produced by the microbiome as it's digesting the different parts of our food matrix. All of those then trigger and react to the lining of the gut. And if in that lining of the gut, your hormonal receptors are not behaving as they used to be, then it is upsetting and disrupting that normal signaling cascade. And that signaling cascade that we talk about when we're talking about the gut and the brain relationship and those gut symptoms that are being experienced includes not only that hormonal response, but also mechanics, because they're all interconnected, they're all interlinked, and they all feed and talk to each other. So if one is is a little bit out of whack, then it upsets the next one. So you've got the mechanism, actually the digestive process of how the gut is behaving and digesting food. You also have other neurons that are being sent up to your brain. And that brain is really important because it is the key organ that tells us how we are responding to stimulus in our gut. So, for example, that normal digestive process of food being broken down and digested, or fermentation occur where there is gas produced by your bacteria, all of a sudden is being interpreted as gut pain, and a normal stimulus turns into a stimulus that would otherwise trigger a pain response.
Okay, that makes perfect sense. So these are direct impacts from the lack of estrogen, but there's also the indirect impact if you are not sleeping at night because of hot flashes and you're very stressed because of that, and then you have less patience, and then you've got this cortisol running through you and you have this gut-brain connection. Well, I imagine as well the gut's going to suffer just because of that hot flash or something like that. That's an indirect mechanism, right, of the loss of estrogen.
Yeah, absolutely. The effect of stress on that system and that signaling makes that signaling hyper aware, hypersensitive. So if it's a disrupted sleep, increased stress, increased anxiety, it could be you've had a stressful day at work, on top of everything else that is going through, that lifestyle change as well is making your body almost like overreact, hyper-react to something that is otherwise a normal stimulus in the gut.
Yeah. And even if you are eating healthy, or quote unquote healthy, whatever that is for you, because I've seen the women I seem to attract in my community are pretty good. Like I don't need to correct their diet. They're not eating a lot of processed foods, and they're eating things that you would call healthy. So it is really frustrating when they're doing all the right things, but yet not getting the results. And that is just horrible. So this is why we're gonna help them through this. But I also am wondering about the woman. There is this sort of direct impact when we lose our estrogen, and you've explained that really well, whereas women had never had gut issues and they're like, where did this come from? But then you have the women who are coming into menopause already with the gut issues. Mm-hmm. And it seems to me that they're exacerbated as they start losing their estrogen, progesterone. Is there any science behind that?
Yeah, I would agree. And a similar scientific rationale for what we've just explained already, in that further change to that hormonal response is then impacting on that signaling pathway and overall disruption to what is happening at the gut level.
Yeah. Okay. So this is why I always encourage women in perimenopause or in premenopause, get it sorted, because it's going to be a lot harder when you get through menopause, and your transition will be so much smoother if you can deal with those things. And I know it's really hard if you're raising babies and families and maybe you have a high powered job, but it is worth paying attention to because your future self depends on that. And I talk a lot about protecting your 80-year-old self while we're going through menopause, because now's a wonderful opportunity to do that. But at the same time, I could say the same thing for a 20-year-old or 30-year-old, is like protect your 50-year-old menopausal self, because she's going to need you when you're going through that. And she's counting on those decisions that you're making today as a 20-year-old. And boy, that's really hard to convince.
I think that like a key take home is just remembering how the gut is ultra sensitive to any hormonal changes. So all those life stages that you've just mentioned there, the gut is likely to respond and could potentially respond in a different way. And of course, depending what else is happening, dietary and lifestyle as well, that the gut is likely to respond in a different way in each of those different lifestyles, just because the gut is so incredibly responsive to hormonal change.
Well, then that's our whole lives as we go through puberty, pregnancy, perimenopause. like men seem to have it much easier. I don't know why, but we're always dealing with some hormonal change. And that's, in the end, a lot of women may not like the word perimenopause. It sounds like menopause. I've even had somebody yesterday, she's like, oh, I don't want to talk about menopause yet. And she's 45. And I'm like, well, yeah. And it's just, let's call it hormonal change. Like it's just a stigma, this word menopause, even perimenopause, that women, and if you tell a 35-year-old who's just starting in very early stage perimenopause, it's like, forget it. They have in their head that stereotypical, it's very ageist thoughts in their head, but it is just, let's call it a hormonal change. And that's what's bringing a lot of this symptoms that we're having in our gut. And I do see women who are told that they have IBS for the first time in this transition as well. So why don't you talk about what is IBS and how women can deal with this during this transition to help themselves?
Yeah, IBS, another unfortunately sometimes term that is stigmatized, and there is a bit of stigma attached to the title. Unfortunately, I do hope that the science and awareness and things and conversations like this helps change that. So IBS, it's an acronym that stands for Irritable Bowel Syndrome. It's incredibly common. About 1 in 5 adults, the prevalence changes as the criteria sometimes changes for the diagnostic framework that we use. But in simple terms, this is a condition where the gut and the brain aren't quite communicating right. It shows up as those gut symptoms we mentioned before, so pain, bloating, and those unpredictable bowel habits. And indeed, we see a lot of women that are being diagnosed with IBS for the first time during perimenopause, and the research backs up that is indeed really occurring, and it's a real pattern. Or that women are first reporting symptoms or in symptoms that are worsening for the first time in their life before and during that menopausal period. So when we think about IBS, comes under a banner of disorder of gut-brain interaction, formerly known as functional bowel disorders. And that word, disorder gut-brain interaction, I've already talked a little bit about that disordered signaling between the gut and the brain, so the brain hyperreacting to what's happening at the gut level. The former definition of it being a functional bowel disorder refers to IBS, a disorder where there is not a one immune or inflammatory pathway occurring or underlying mechanism that you can go and get a blood test for, unfortunately. It is a diagnosis made on the basis of a symptom cluster, symptom pattern, and severity of those symptoms. If there are symptoms that first experience that would be deemed a red flag for further investigation for celiac disease, which is an immune condition, or inflammatory bowel disease, including ulcerative colitis or Crohn's disease, that's where you would go on and have further investigations, blood tests, and scopes. But for something like irritable bowel syndrome, where we know that there can be lots of different types of triggers, diet, lifestyle, hormonal change, may come on also after a bout of gastroenteritis, traveller's diarrhea, and we know is linked with the gut microbiome, is significantly linked with other psychological conditions. We see higher rates of things like anxiety and depression in our participants that have IBS. So a really heterogeneous condition. But the positive thing is that we now have lots of different ways that have good evidence base for how we can manage symptoms for somebody that might be experiencing something like IBS for the first time.
What are some of the most common symptoms of IBS?
So gut pain is the key symptom that the diagnostic criteria will be based on, how severe and how frequent that gut pain is being experienced. And when I'm talking about gut pain for irritable bowel syndrome, this is focused more on the lower bowel region, so the lower gut region. If you're experiencing upper gut pain, so around your stomach or even reflux, that would perhaps indicate another type of disorder of gut-brain interaction, functional dyspepsia, or even something that may be related with reflux itself. For irritable bowel syndrome, that gut pain, so lower down where the large intestine or colon is, bloating, distension, where women or participants, patients will often report feeling that they look pregnant when they are not. And it can present as being either constipation dominant, diarrhea dominant, mixed in being varied between those two as either of the dominant symptoms, or unsubtyped and varied, where patients will report that their symptoms and their bowel habits and dissatisfaction with that bowel habits being very unpredictable. And those are the main gut symptoms. We do also see, because of that overlap of the psychological conditions, other non-gut symptoms often reported and experienced concurrently as well.
Non-gut symptoms like what?
Fatigue being a main one, and brain fog. And we don't truly understand how that mechanism is at play, but we do see across all of the literature and studies in this space that there is often both the gut symptoms, which is what the diagnosis is based on for IBS, but there is often a very high level of non-gut symptoms also reported. So fatigue, foggy mind, having difficulty concentrating, feeling a bit sleepy and foggy.
Yeah, this must be so hard to sort out if this is menopause or is it gut, or it's probably both, because you could treat the menopause, and maybe if the brain fog doesn't go, then maybe it's the gut or vice versa. So you did mention something about the brain controlling the gut and giving these signals. And so I'm wondering how, if somebody's having these issues, and I can't relate to this, I haven't yet, hopefully not, had these kind of issues, but I hear a lot about them in my community. And I can understand the stress that somebody must feel if they're actually feeling pain, or they're like, oh, I know when I'm going to eat this, it's going to be horrible. But at what point is it sort of subconscious? If somebody's like, I'm not stressed, I'm totally like, I feel, and maybe they are, they're not, feel in control. And there's that mechanism, like you said, digestion. The brain is digesting this like we're not telling our brains, okay, now go and digest. It just happens. So I want to understand a little better on how that brain controls what's going on down there, and how much can we control our brain to actually tell it to do that.
Yeah.
Does that make sense? I don't know. I don't even know how to frame this question, but I'm very curious. I feel bad for those people who are like, honestly, I feel fine. I don't have that stress, but they still have the gut issues.
Yeah. And so there's a couple of things that I can touch on. The other thing that we often see on top of this highly, like the levels of anxiety and depression, but are also other characteristics like anxiety around food, fear of food, in the thinking that particular diet components may be triggering symptoms. So although there may not be a baseline level of and you meet a diagnosis for having anxiety, but you may have gut-specific anxiety or food-specific anxiety. And with that then comes a level of hypervigilance, where you are then effectively putting your brain automatically, subconsciously, is becoming hyper-aware, hypersensitive to any normal stimulus, to any normal digestive effects that are occurring throughout your gastrointestinal tract. And so it may be something that you used to be able to tolerate just fine a couple of years ago or last week. Suddenly you can no longer tolerate, or you are experiencing those digestive effects as pain, as flatulence, as bloating. So like physiological changes. And when we get to talking a little bit more about my research, where some of the work that I'm doing at the moment is trying to understand how we can study and use that idea of being able to retrain the brain and how that brain is indeed interpreting those signals. We have very good evidence from the psychological field using models like cognitive behavioural therapy, gut-directed hypnotherapy, particularly in the IBS space, where that whole aim of those treatments is to effectively retrain or dial down how the brain is responding to those gut signals that we're otherwise overreacting to.
Okay, I can understand these pain pathways because somebody who's been through osteoarthritis and then eventually 2 hip replacements, but I did some brain retraining because I understand that hypervigilance. When you have a pain, you're like a hawk looking for it the moment, whatever you eat probably, or I move. And it does help. For me, it didn't completely take the pain away, but it did lower that because I get it. I understand that pathway. So then retraining would be one of the things that we could possibly do. But I'm wondering, I don't know if I asked you this before, I can't remember. There was an app that maybe I've told you about that it was specifically made for the gut. And it was an app and that I was told there was probably meditation or something in there. And I can't remember the name, but it kind of makes sense to what you're saying now, that somebody said, look, okay, if we can retrain the brain and make somebody feel more relaxed and more calm and less paranoid about food or something they're eating and this pain, then maybe that will help. I'm wondering if you've heard of these kinds of apps, and do they really work?
You may have been referring to, there's a particular app around at the moment that focuses on using a gut-directed hypnotherapy model, where indeed there is, and it's come out of Melbourne here in Australia, and there is indeed research, if it's the Nerva app that...
yes, Nerva app.
That was it, Nerva? Yeah.
Yes.
So it uses quite similar theories that underlie it to something like cognitive behavioural therapy, talk therapy, where you are then retraining how your brain is responding to something at the gut level. And there is very good evidence to come out to show that both a gut-directed hypnotherapy model of treatment, as similar to a CBT, cognitive behavioural therapy model, also work as well, particularly for somebody that is experiencing IBS symptoms.
Oh, cool. Oh, that's good. That's good news. Yeah. If anybody's listening now and you've tried that app, please tell me if it works, because I got a whole community of women ready to try it. The other question I had is, we were talking about menopause and the loss of hormones and women experiencing more gut issues. I'm wondering if women are experiencing more gut issues than men in general.
Yeah, I often get asked this question, and I have to be delicate in how I answer it, because I think the answer is yes. However, it is very difficult to be confident in that answer, because if you look at research and science, a lot of our research participants and studies are more frequently the participation rate is more frequent in women. So it is hard to know, are we just looking at a higher evidence base because women are more likely to participate in these types of trials? Or is it indeed more frequent and more experienced in women? We definitely do see IBS and gut conditions in men. It's not that they don't experience it, but I would say without a doubt in all of the studies that I've ever done in this space, and from what I've also read, that there's always a higher rate of women participating.
All right, seems to me the same. So I have so many questions. I'm trying to think where to even start next, because I would like to explain the reasons why we have these issues other than hormone loss, right? And what are the root causes of these issues? And it's probably different for everybody, but how does it get triggered by something? Habits from childhood, other than menopause and hormones? What's the root cause?
Yeah, it is different for everyone. And we sort of talked about the hormonal change. I mentioned earlier on in the conversation about we often see onset after traveler's diarrhea or a bout of gastroenteritis. So where there's the change in the gut microbiome, and I'll talk a little bit more about gut microbiome in a moment. Another thing that is coming through in the research more recently and definitely in clinical practice is particularly early life trauma or something that has happened in previously throughout life that has then made that hypervigilance and underlying anxiety, perhaps looking at that gut-brain signaling again. Whether there has been a change in diet, whether there has been a change in other lifestyle, medication, antibiotics, that has then also changed how that digestive process is normally occurring, how that microbiome occurs. And changing diet is obviously coming from a nutrition background, something that I've worked a lot in, and looking at how particular diets and particular foods may underlie the onset of some of these symptoms, may be responsible for triggering some of these symptoms. And then importantly, how can we manage excluding or reducing those foods, but then importantly, bringing and reintroducing them back in. So one is not following a lifelong elimination or restrictive diet, and that how we can then re-challenge and work out a protocol to be able to reintroduce those foods and expand them and rebuild tolerance. So diet is a really important trigger there. So yeah, I've touched on psychological conditions, hormonal conditions, microbiome and things that might change that. And that's where it may be antibiotics, gastroenteritis, any other hospital visits, where you've been exposed to something that is effectively changing your gut environment.
This is actually a perfect example. In gerontology, we talk all about adverse childhood events and things that have happened in your past, in your youth, or it doesn't matter, have to be your youth, but all throughout the course of your lifespan can affect the diseases that you get later on in life or the things that are happening. So this is just one among many other things that can happen. And it's not your fault. Things happen. This is life. And now we have to deal with it. But I'm curious, what about genetics? Can be a factor here?
Yes, the evidence isn't hugely strong or dominant to the point that we can't recommend a genetic test like you can in celiac disease per se. There are some studies that say that there is some relationships in family lines and genetics, but the data is not strong enough to say that there is this particular genetic type that would put you at a higher risk.
I did a couple of years ago, probably about a year ago, I did a DNA microbiome test. It was I can't even remember the name. So gave it to me at a conference. And I thought that was really interesting, but I guess it's not enough evidence behind it, but I didn't pay for it, so it was okay.
Were they screening your microbiome then? So they were looking at actually your bacteria composition in your gut?
It was through a blood spot test.
Okay.
And so I did it there in the conference, gave it to them in the envelope. And then several weeks later, they gave me my results, which I don't remember anything that stood out from it, but it was specifically made for the gut and your DNA. So I'll have to remember the name.
Yeah. And the thing that we probably haven't emphasized enough is that IBS, it can come and go, right? In that it is a chronic condition. Have very good ways of managing it. There isn't a cure per se, but what this means is that those genetic tests often, and we have other tools that have been used across the sort of last couple of decades in the IBS space, breath testing and things like that, where they don't always correlate to symptom response or clinical response, because we're also very heterogeneous. And even thinking about the symptom patterns that we see in our IBS patients, the symptoms may not be every day, and they may come on in bouts And they may come on in bouts where there is a high baseline stress, diet hasn't been so good, you're not sleeping so well, and that's when IBS flare-ups are occurring. So it makes it really difficult, therefore, to look at the evidence, because when you're trying to correlate it to who's got IBS, it actually can be a condition that comes and goes.
And it seems very often when I see women in my community speaking to, because we have doctors and researchers coming on all the time is for live Q&As, and hopefully you'll be there too. But when we share reports, like gut reports, I would say 3 out of 4 times it's the person I've invited, the guest has said, oh, this is stress. This is stress related. It's more often than not. So it seems that there is a huge impact. And the girls then confirm it when they kind of take a shot out there. Like I'm guessing stress. They're like, yeah. So it seems like there's a very close correlation with stress in the gut.
Yeah, there is. And where I would only add there that it's important to not then use stress as, it's like without dismissing it, in that those gut symptoms are real, to ensure that those symptoms are validated, that physiological response is occurring. We know that stress is just adding to that hypersensitivity and that response of that gut-brain signaling that is occurring.
Okay, I want to hear a little bit more about your clinical trial. This is an international clinical trial, and you've got 2 different treatments for IBS, the low FODMAP and then exposure-based cognitive behavioral therapy, which is 2, one is mind, one is body. Can you tell us a little bit about the trial and how women listening today could actually even take part in it?
Yeah, excellent. Thank you, Zora. So if you are listening and you do indeed experience IBS or gut symptoms, I'd love to tell you a bit more about this study. So we are looking at diet, and what we're looking at here is the low FODMAP diet. Now, the low FODMAP diet is one of the most evidence-based dietary treatments. We have very good evidence base to show that the low FODMAP diet will improve symptoms in 3 out of 4 IBS patients.
Maybe explain what a FODMAP is in case people don't know.
Yes, of course. Yes, very good. I talk about FODMAPs all day, every day. So it's become my second language. So I'll start from the start. So we are looking at the low FODMAP diet. The low FODMAP diet is where we focus on a group of fermentable carbohydrates. FODMAPs is a very long acronym that stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. You don't need to remember all of that, other than it is a group of carbohydrates that are naturally found in different types of foods: fruits, vegetables, wheats, grains, lactose in dairy, polyols in stone fruits, honey, mango, a long list. Importantly, we do also have a long list where FODMAPs are not found. And over the last 15 years, and the FODMAP evidence came out of Melbourne, we have very good evidence to show how the FODMAP diet can lead to symptom improvement in people that have IBS. But the catch here is that it doesn't work for everybody. And we would now like to know, how can we better predict who the FODMAP diet is most suitable for? And so the FODMAP is effectively the approach that you would take if you were seeking out and you particularly feel like your gut symptoms come on after diet. You would see a dietitian and they would take you through a 3-phase approach where you are restricting FODMAPs, reintroducing FODMAPs, and then being educated on how you can expand your diet lifelong and build up that tolerance. And that's the typical approach for the low FODMAP diet interventional treatment. And that low FODMAP diet is now recommended in clinical guidelines around the world for gut conditions. On the flip side, we have something that is also looking at the brain. So cognitive behavioral therapy, particularly exposure-based cognitive behavioral therapy, where, as I mentioned before, we are retraining how the brain is responding to foods. But this particular model of CBT is actually, the exposure is re-exposing foods and retraining your brain as to how you're responding to those foods. Now, interestingly, both the CBT model and the FODMAP have similar efficacy or similar effectiveness. So they work for up to 75% of IBS patients. In this study, we're really interested in trying to understand who responds to which treatment best and how and why. So trying to better predict very early on and trying to reduce the trial and error and long journey that many IBS patients will have to go through when they're trying to understand what is their own individual symptom trigger and how can they help manage their symptoms. So the trial that we're running is all online, open to anybody that has IBS, based all across America as well as Australia. if you're interested, please go to our study website, which is www.gutresearchstudy.com, and you'll be able to find out more information and about the study, what participation involves, and express interest. So you're randomised, which means you get a 50-50 chance to either the diet arm or the CBT arm. During that 12-week treatment period, you have a clinician, so either a dietitian on the FODMAP arm or a psychologist on the CBT arm, that will work with you individually through that 12 weeks as you learn about that treatment and hopefully feel some symptom improvement. Does that give a good summary of the study?
You said it's open to people in Australia and the US. What about Europe?
Not at the moment, just because we have all of our resources are adapted for the American market and the Australian market, but watch this space.
And by when does somebody have to jump in to participate?
So at this stage, we'll be running the study up until November this year. We have had about 130 people already finish. So we're about halfway. For these types of studies, for us to be able to do really impactful, meaningful statistical analysis, we need a really large number of people. And yeah, so if you're interested in taking part, go to our website and find out a bit more information, and you'll be able to follow the screening survey to see if you're eligible.
Oh, wow. This is so great. So we're talking about November 2026. And so if somebody jumps in November 2026, like if they listen to this way after it's republished, they can still jump in because you're going until February kind of a thing, because it's 12 weeks?
Yeah, indeed. And so it's a 12-week treatment. Importantly, we actually have a couple of follow-up time points after that where we actually check in with the participant, see if they've got any questions to ask the clinician that they had worked with, or with the study admin team as well. So it actually... participation will be for 6 months, but that main treatment intervention period is only for 12 weeks.
And to qualify, men, women, age?
Adults, so 18 years of age and above. We have no upper age limit, men or women. And ideally, you have seen a healthcare professional to have received a diagnosis of IBS. And so if you haven't seen a healthcare professional for your gut symptoms, I do encourage you to do so, particularly because some of those symptoms, if there is new onset of those symptoms, particularly after the age of 50, it's important that they're screened by your family physician and discussed alongside any other red flags that might be in your family history.
Okay. Do you know Cynthia Thurlow? Have you heard of her?
Yes.
She wrote Menopause Gut. So it's a book, Menopause and Gut Health, and she's got a great podcast, and I would love to connect you to her because looking for participants, I'm sure she's got a big following of women with gut issues, or men too as well. I mean, it's just great. Okay, that's really cool. I have a question then about, and I don't want to forget, I know it's a little, I don't know if it's off topic or not, parasites. What is that real? Are people exaggerating? Because I see so many people online and social media and they show the little parasite. And sometimes I get a little skeptical. I know it's probably real, but how real is this? And are people taking advantage for marketing purposes?
Possibly. But if there is that, so it's a parasite that they are finding in their gut or in their stools.
There's stools. They're usually coming out of stools and they show a photo of it and it's like disgusting. And people go, oh my God, I want to do your parasite cleanse. I haven't done I'm not interviewing people yet about that, but I'd like your opinion first. There's tests out there that do test for parasites. So I'm thinking, well, they must exist.
So they do exist. I don't know whether there is any good clinical trial data enough to say yay or nay what the relationship is to a point of diagnostic or testing purposes. But at the end of the day, if there is something that is going to be disrupting that gut environment and how that gut is then digesting food and absorbing nutrients, importantly, it is likely to be upsetting that gut-brain axis and also then leading to some symptom experience. Yeah.
Okay, to be continued. Let's talk about the gut microbiome, because you mentioned that a couple of times and we do hear about it a lot in the menopause space. So let's define what is the gut microbiome and then what we need to know about it.
Yeah, excellent. There's so much. You'll have to please pause me wave at me if I start to ramble too much. So your gut microbiome is basically the community of billions or trillions of bacteria living in your digestive system. They are really important because they help digest your food, they support your immune system, and relevant today, they're interacting with your hormones and they talk to your brain too. So really, they're like a powerhouse and they do lots of important things. Importantly, when we look at and understand that gut microbiome, all of those bacteria that are making up your gut, and particularly in the colon, so the large bowel, so go lower down and where all the bacteria are residing. That's their happy place, mainly because of pH and their environment that they can survive in. We have because there are so many trillions of different types of bacteria, that diversity and makeup composition of bacteria becomes very individualized. And this is why things like the stool testing for microbiome and the relationships to health and disease is evolving. And we are still really quite in our early days in understanding how, because it's so complex and individualized, your gut bacteria composition, your healthy balance will be very different to my healthy balance. But what we do know is we have some very healthy, beneficial bacteria that we do definitely need lots of. And we have some more harmful bacteria. And that's probably a nice segue back to the parasites. What the parasites are not great for, they're probably depleting the good bacteria. In terms of like life stages of the gut microbiome, really early on, where obviously when we are born as babies have no microbiome, and that is in that first 2 to 3 years of life is really important for when that microbiome diversity and composition is establishing. And we want the more diverse, the better, because all of these bacteria are doing lots of different things. So really it's like having a beautiful garden. If you can have the more different plants you can have, the better for how beautiful it is. And across that lifestyle into early adulthood is when we'll see sort of establish. And then as we go on from older adulthood in through the aging years, we will see that composition deplete and it become less stable. And that is mainly because of the things that we will be exposed to, whether that is pollution, stress, changes in diet, medication, less diverse diet. And from a diet perspective, the things that feed your bacteria are things that are adding to that the bacteria can ferment. So those fermentable carbohydrates that I mentioned before that come under the FODMAP term, but foods that are particularly plant-based, things that have already a prebiotic load, so already have live bacteria, things like your yogurt, your kimchi, your kombucha, all of those things are really good for your microbiome. I will pause before I ramble too much and make sure that I'm still on track.
It's so interesting. So I know the microbiome has the gut in general has a huge impact on our immune system. And I understand, when you're a child, you get sick a lot too, right? I always say, you're getting an upgrade. Your kid's getting the cold or whatever. And does that impact the gut? Probably. But I also heard that as an adult, the adults will have or young adults will have a more similar microbiome to their roommates than they will to their parents. And that's, to me, shows your lifestyle has a huge impact on the gut.
Yeah, as do having a pet. Absolutely. Where you live and having a pet are like the two most influential factors for microbiome. And so I'm not surprised at that fact at all.
Okay, having a pet, meaning dogs and cats, like how does that help or hurt the microbiome?
It helps. It helps. So just because you are being exposed to, you think about everything else, particularly if you don't have a housebound pet where it's a pet that may be roaming outside. And so just being able to pick up more diverse environmental bacteria, and that you are then, as you're snuggling and cuddling your pet, you're also ingesting or inhaling and taking on as well. So it is adding diversity. The more we can do to add diversity to our microbiome composition, the better.
This reminds me of a friend of mine. As we were raising our children, she was a hypochondriac. And so she would completely sterilize everything and not let her kids be on the floor or roam around or touch things, put things in her mouth. And at the time, I didn't know very much, but I remember hearing that that's probably not a good idea. And her kids were constantly sick. And her excuse was, well, if I'm not this clean, they're just going to get even more sick. And they had all kinds of problems. What's wrong with this story here?
It aligns with the hygiene hypothesis. And so I've heard that many times because now we've perhaps become quite germaphobe, and we still see the hangover from COVID where hand sanitizer is everywhere. What effect is that having in being able to then expose particularly our younger ones to different types of bacteria, and just go out and play in the dirt? Go out and explore the bush and the forest and the beach and expose yourself to as many different environments as possible.
Yeah. I'm wondering then, in terms of solutions, let's talk about solutions. And one question I do have before you dive into all the things that we could do, because you did mention the FODMAP solution and the CBT solution. But if hormones is part of the root cause, then would adding HRT help? Or do people get worse on HRT when it comes to the gut microbiome?
Yeah, good question. I don't know, because we do see that interconnection or the link between hormones and microbiome. Yeah, I would have to look up to see what the evidence is in that space. And Zora, I wonder if you've heard of the estrobolome concept, which has recently been coming out, and whether you've chatted about that in any other conversations.
Not much
idea
so.
of,
So you talk
okay,
about it, because we've just touched on it.
because and I wonder if it sort of helps link to a bit of like understanding of the hormone as well as that gut microbiome. And I think it's worth introducing, because definitely within the right research and science field where it's a bit of a hot topic at the moment. So the estrobolome, this is a term that we're using for a collection of gut bacterial genes that are reactivating estrogen that the liver has otherwise really packaged up for excretion. And we're seeing a nice sort of like way of thinking about it as like a single concept for how the gut and the hormone, and they're linking it all, and that your gut microbiome isn't just reacting to hormones, it's actually helping recycle them back into your body. Yeah, I wonder if we either come back and revisit it as a whole separate conversation, because there's some great research coming out in this space as it's being more explored as well, and understanding how, if we can be able to understand what this particular collection of gut bacterial genes are, whether that offers something for added treatment, prevention, and targeted therapy as well.
Okay, we're going to go revisit that space on another conversation.
Yeah.
And that'll be super interesting, and then hopefully offer some solutions. But some women actually are finding solutions by cutting out gluten or dairy or other food groups, and some aren't and feeling worse. So what does the science say? And is there a smarter approach?
Yeah, so food intolerance and restrictive diets is one of my pet passions. For a long time, I've studied whether gluten intolerance exists outside of celiac disease. So I will start by just defining the two and making sure that people understand the differentiation. So celiac disease is an autoimmune condition, lifelong condition, where your body is reacting to gluten as if gluten was foreign. It starts attacking the lining of your small intestine. It's genetic. We have a blood test for it where you not only pick up the antibodies, the genes, and then you can also have a scope to look at the damage happening inside of the small bowel. That is celiac disease. That is the medical treatment for celiac disease is lifelong, strict gluten-free diet. Then we have a cluster of other conditions, food intolerances, food sensitivities that sometimes get called gluten intolerance. Over much of my career has actually tried to understand whether gluten can indeed trigger symptoms outside of celiac disease. And a couple of key messages, because we see the gluten-free diet pushed a lot from food industry, from the media, celebrities, lots of celebrities claiming the gluten-free diet has helped them from not just gut symptoms. We're talking about weight loss, fatigue, every sporting performance, everything under the sun. So when we think about gluten, where we often find gluten is a protein that is found in wheat, rye, and barley, so grains. When you have something like a bowl of pasta, when you're eating that pasta, in that pasta, you have the gluten protein component, but you also have a carbohydrate fructan component. That fructan component is actually a FODMAP, is actually a fermentable carbohydrate. But then when you have that pasta, you probably also have a sauce on top. There may be onion or garlic. Onion and garlic also contain fructans. There may also be a tomato-based sauce, which contains something called salicylates, which is a natural food chemical that we know can also sometimes trigger a similar set of symptoms. And maybe you've had it alongside a glass of wine or a cup of coffee after a stressful day of work. So lots and lots of different potential triggers there that could be underlying why somebody would eat the bowl of pasta, feel really bloated, experience gut pain, maybe running to the toilet. You go to Dr. Google says pasta, gluten. You've got a gluten intolerance. If we go to the evidence, and if we go to the evidence and the scientific studies, we've got lots of really well-controlled, randomised, double-blind controlled studies where we are studying people who believe they have a non-celiac gluten intolerance, challenging them with gluten or with fructans or with a placebo in a blinded manner. Consistent trends are coming out in the data that shows gluten is actually not triggering a symptom response, that it is the fructans and, interestingly, the placebo. So this is where, in this instance, in this field, we are calling this a nocebo effect. So the opposite to a placebo, where these participants, and I see it also in patients and not just in the research setting as well, have such a negative expectation and belief in that I'm going to feed you gluten and gluten is the devil, and it's going to trigger you symptoms that no matter what I put in front of you, you experience physiological symptoms because of that wonderful gut-brain axis that we've talked about. So it's a little bit about the gluten field, and
Can I ask you
very
one
complicated.
question? I'm just curious. Yeah. It is a crazy experiment. Because I was waiting for you to have that nocebo effect. And because I do meet people who would just have absolute fear before they put something in their mouth. And I'm like, what's the signal your brain is telling your body before you put that in? I don't know. And maybe they really do. I always wonder about it. But how do you get someone to say, eat gluten, and tell them this is not gluten? Because if they see a piece of bread or they see pasta, or you just tell them this is gluten-free pasta and it really has gluten in it. Like, how do you do that?
So in our research studies, we will be having a 6 to 12 month workup of experimenting in the lab and kitchen, of being able to design foods that look and taste and appear exactly the same, but yet we are altering the ingredients of either the gluten or the fructan component. And from a research setting, we tell the participants throughout that informed consent process that we will provide you with 2 slices of bread and a muffin every day for the next 6 weeks. You have a 50-50 chance of whether it's going to contain gluten or not. It will, and for other foods, whether we're like mixing it into a yogurt or mixing it into a soup, or whether we're hiding it in lots of different doses across the day and providing all meals to them. So there's a bit of acceptability and testing, and a lot of working with hospitality chefs to ensure that it's palatable, but yet you cannot tell the difference.
Okay. Yeah. I'm curious. I was curious. Because that's a big factor of what's going on in your head too.
Correct.
And that would determine if this study is about that. So why don't you continue? Because I just totally interrupted you.
Oh, no, all good. I was talking about why cutting out foods don't necessarily work, with the example of people self-diagnosing as gluten-free being a really interesting and complex scenario, but something that we are still seeing over the last 20 years since the gluten-free diet has been marketed really heavily. The why it doesn't work is because it adds to that fear of food and that anxiety towards cutting out something, because that person who's gone to Google and Google said it's gluten now self-experiments with cutting out what they believe are gluten-containing foods. And there are a couple of issues there where if they haven't seen a dietitian to help understand where gluten is truly and accurately found, then they may not actually be cutting out gluten. Because gluten is because of its food science properties, it is used as an additive in lots and lots of different types of products. It's a thickener in soy sauce, for example. It's found in medication coatings. So it can be in quite tiny amounts, but it still is scattered throughout the dietary supply. But because we know fructans and other FODMAPs are found in that same meal, how does one then understand what is the true trigger? So then you create a misbelief, because actually you've tried cutting out gluten, but you haven't experienced any improvement in symptoms. So then you just start cutting out lots of other things, and that sort of perpetuates that negative relationship with food, that negative expectation, that anxiety around eating, and which may then lead on to having social consequences. You don't want to go out and have a meal with your friends. You don't want to go over to a friend's house because of a fear of what's going to be served to you. But actually it comes down to not being able to have accurately understood what is the true dietary trigger. And that's because food is really complex. That food matrix and what is on that bowl of pasta and everything else that we've eaten before during the day is also really complex, and there's lots of things that can be potentially triggering those same symptoms. The added risk here is if somebody already starts removing all of these things from their diet, is nutritional adequacy, and therefore risk of being depleted in really important nutrients, particularly if we're talking about important periods of the life stages and life cycle. And that following a gluten-free diet can be more expensive, because we know if you're choosing gluten-free bread versus a normal containing bread, it can be more expensive. But importantly, that you may be missing out on accurate diagnosis or investigation of having something like celiac disease. So the only way to have celiac disease adequately and accurately diagnosed is via gastroscopy, where they go in with a scope down into your small bowel and they're looking for that damage where your villi that line your small intestine are damaged because of that autoimmune reaction that is occurring. And if the gastroenterologist can't see that damage because you've already been following a gluten-free diet, so your villi have already started to recover, then you're not going to get diagnosed as celiac disease. And the complications of that is that you are then not screened for ongoing risks and complications that are associated with celiac disease. Things like osteoporosis, things like low iron, infertility, lots of other conditions that can happen concurrently with celiac disease. So it's accurate or misdiagnosis of other health conditions, nutritional adequacy and relationship of food, and being able to identify the true trigger of what a dietary trigger could be.
So are you saying that if somebody has celiac and they don't know, they're not really sure, they don't know, they just know that when they take out gluten, they feel better, that the problem with that is that they may, by not having the diagnosis of celiac, they may not understand that they are more at risk of X, Y, and Z diseases or issues. That's correct?
Correct.
Okay.
Yeah. And here in Australia, I believe in many other countries, I don't know each country specifically, but there are discounts offered for somebody that has a celiac disease diagnosis, where you can then get a discount off being able to purchase gluten-free products as well. So there's extra support. You then are able to see a dietitian, get well trained on how to follow the gluten-free diet in a safe and nutritionally adequate way, as well as that regular screening with a specialist to ensure that you're being screened out for any of those other complications that we can see with celiac disease. So if you do think that gluten might be a trigger for you and you've already started to reduce or play with removing gluten from your diet, I would strongly recommend you to seek out your family physician or a specialist to ensure that you can get tested for celiac disease before you've been on a strict gluten-free diet for a long time.
What was the result of the study that you did with the gluten eaters and the non-gluten eaters?
Where we challenged them with the fructans and the placebo, or
the placebo, where they didn't know if they were eating gluten or
the nocebo study. Yeah, okay. So in this study, we recruited people who had non-celiac gluten sensitive. So celiac disease has been excluded. They self-report as being gluten intolerant. We are looking at what the aim of the study was to actually see if there was a dose effect. So we provided them with all of their meals for 3 weeks. 1 week had no gluten hidden in it. 1 week had a low gluten amount hidden in it. And 1 week had a moderate to high amount of gluten hidden in the foods each day. And what we found is that no matter what people received, and it was all randomized, all double-blinded. So although I cooked all the food, I had another of my colleagues do all the labeling. No matter what people received the first time in that first arm was when they felt the worst symptoms. And we have a scientific term called an order effect, where that expectation towards experiencing symptoms was so strong that it didn't matter what they received first. That was when they felt the worst. And in fact, when we then analysed and broke the code, we found that there were no differences between the 3 groups, but yet there was a worsening of symptoms across the 7 days that sort of aligns with this nocebo response and negative expectation. And we've actually got a really good study that just recently came out last year from Maastricht in the Netherlands that actually mislabeled on purpose what they were giving to their participants. So a similar type of participant cohort, non-celiac, gluten intolerant, provided and challenged with some bread that contained gluten, some bread that didn't contain gluten. And in this study, they incorrectly told participants what they were receiving when. And so it's a bit of a complex design.
Yeah, no, I get it.
The main take home is that when participants were told they were receiving gluten, but it wasn't, it was a gluten-free bread, that was when they experienced the most symptoms, stronger than when they received the gluten-containing bread. And so we've now, over the last literally in the last 2 years, we've had a number of different studies. I had one come out with my colleagues in Belgium, one from Canada, this one in Netherlands, that is showing this nocebo response, where this idea of telling people that I'm going to give you something that's making you sick is when those people were feeling the most unwell. Of this negative expectation and the power of beliefs towards your illness and experience, and that fear of experiencing those symptoms.
Wow. Okay.
Yeah.
This is very Joe Dispenza-like. Dr. Joe Dispenza, I don't know if you follow him, but the thoughts in your head can have a big impact on your body, which we know it's true. He's got lots of meditations for you if you want to go down that route. But that is incredible. So then that's a really powerful thing. And actually, if you do believe what you just said, then there's actually a lot of power in your hands to change the trajectory of your gut and how you feel, how you're feeling about it and your pain. I'm curious then, is gluten bad at all for people not with celiac disease?
No, it's not. I love gluten. I love gluten. And you know what? Gluten is found. I love gluten. I've been studying gluten since my honours research year. So 20 years ago, I first started exploring this area of gluten intolerance. Gluten is found in so many wonderful foods. Your whole grains and your cereals are so important for you. And if somebody has been playing with cutting out gluten-containing foods, making sure that you are on top of things like your B vitamins in particular and your fiber, if you've been cutting out lots of your grains and cereals and that as a whole really important dietary group, perhaps re-challenging with small amounts because, to build up your trust in that as a food that you can have a good relationship would be great.
Oh, I'm so happy. I eat gluten, but not a lot. I'm like, maybe I shouldn't go overboard with this stuff. There was a period of time where I was trying to get more and more protein in my diet. And so I would literally buy gluten for baking, like just pure gluten. And I was like, maybe that's pushing it. But I'm really glad to hear what you just said so I can continue on my trajectory.
Yeah, please do.
So then I guess we don't need, because there's a lot of people talking about, in Europe, there's a lot less gluten in the bread than there is in the US. I don't know what it's like in Australia. And everybody, I've been watching so many people on their stories, these Americans who go to Europe and they're like, I can eat dairy and I can eat gluten and I don't feel. And so their explanation is, the dairy is raised differently. The wheat is totally raised differently and there's less gluten in it. And it's very believable, but I don't know how true it is anymore now.
Yes, I have been contacted by a few journalists on this topic, and there's a couple of things to think about here in that, and it all comes, I think, in my opinion, is that it comes down to the gut brain and how if one is on holidays in Europe, how relaxed we may be otherwise feeling. Maybe we're doing more walking and exercise because we're out and about and seeing the sights. And we are otherwise not in the daily grind of the work stresses and other things that might be happening in the 9-to-5 lifestyle at home. And that may be, a key reason for why there is an overall experience of feeling improved health and reduced symptoms. There is definitely some truth to their food supply and the growth of things like grains and cereals and crops being different from areas of the world. Australia is dry, and our crops that we produce here, we think about fructans as a carbohydrate component being the storage source for the whole crops plant. So our composition and makeup of how many fructans versus the protein component in our crops will differ to somewhere that may be in Europe where it's more of a wetter condition. Whether that then translates directly to once it's then processed into a bread, that it actually doesn't trigger symptoms. We don't have the research to say that. But there is definitely some differences in how that grain is being grown, and that is environmental. And then it would come down to the processing. And of course, buying a baguette from the French baker on the corner versus your packaged plastic bread in the supermarket, there would be some differences in your ingredients and how it's being processed and refined.
But that's totally different than the wheat. Like if in France, when you go to the supermarket, there's the packaged bread in the plastic thing and a list of ingredients. And so that wouldn't be as my first choice as opposed to just getting a fresh baguette. But are they both using the same wheat from France, or do we know?
They're probably not. I could find out. They're probably not. And that there would be a lot more care taken for where they are sourcing and supplying their flour from. Yeah.
Yeah. Because I'm just honing in on the argument that it's the gluten in the wheat that is this versus all the other garbage that's in the plastic bag, which could be causing problems as well. Okay. I feel like we need a part 2 to this because I want to take another dive, but let's just wrap up with a few fast questions in terms of what is the worst thing that we can do for our gut microbiome and overall health that we should be avoiding?
Perfect segue after talking about plastic bread. So the worst thing you could do for your gut microbiome and overall health, we're thinking about you want to reduce how you can live in a way that is removing any diversity and rhythm to the body. So you don't want to you want to avoid eating a highly processed, low fiber diet. You want to ensure that you have good sleep, reduce your stress levels, good physical activity and avoid taking medications, particularly antibiotics, unnecessarily. Anything that we can do to feed our gut microbes, that adding to that diversity and adding to that ecosystem. So variety, consistency, and exposure to high fiber foods.
Okay. Yeah, you just did the inverse. So if you want to continue to have a bad gut, then forget the exercise, keep eating the highly processed foods, stress is best, and stop exercising. You can keep going with the meds and those kinds of things, and don't add variety. I have to make a reel like that.
Yeah.
Because that's probably what a lot of people are doing anyways. And it highlights the things for the gut. But let's then ask what is the biggest myth about the gut that you wish to correct?
So the biggest myth is that more isn't always better. So you don't necessarily need more probiotics, more restriction of particular foods. And for you, it's often about coming back to for one individual, it's often about just coming back to the basics, the fiber, the sleep, move regularly, manage stress.
Oh, wow, that's great. The biggest myth you disrupted for me was the gluten thing. That's pretty big. So really excited. I hope you can come for a part 2, because I do have a lot more questions, but we have gone over the hour now. And I just want to let you go to bed now. You're in Melbourne, right?
Yes, yeah, correct. Yeah,
okay.
Down under.
Time for you to go to bed. But I would love just to reiterate again, if somebody wants to participate in the clinical trial, what was the website again? I'll have it linked in the show notes, but just you can repeat.
Yeah, it is gutresearchstudy.com.
Okay, wonderful. Oh yeah, gutresearchstudy.com. And I've got your email as well. If people want to reach out to you, have some questions, and I've got some other great links on Instagram, Facebook, and Twitter. Thank you so much, Dr. Biesiekierski. And we will hopefully have you on again for part 2. And thank you everyone who's listened to the end. If you found this intriguing, please share it with a friend who needs to hear it, especially that friend who's very scared of gluten. And please come on again. We wouldn't be here without you. So we appreciate your time. And thank you so much for your time to Dr. Jess. Take care. Have a good day.
Thank you. Thanks, Zara.
Bye-bye.